We start. Okay, we can start.
There's music playing in the background. Shall we start?
Yes, please. Sorry.
Okay. So, good evening and welcome to another edition of live online Crosstalk on East Kolkata Doctors Group. Today, we are going to be talking about three very important areas which today have come to define diabetes care: glucocentricity, adipocentricity, and organocentricity. Not necessarily in that order. It was glucose, then we went to organs, and now we have started taking this downstream, upstream approach called the adipocentricity. And to discuss this today, we have two experts with us: Dr. Tejas Shah from Bombay, an eminent diabetologist, and Dr. Samit Ghosal, an eminent diabetologist from Kolkata. So we will start off this session straight away with a question that we will go ahead and ask Dr. Shobit Ghoshal. Tell us, why did glucocentricity fall into disfavor? It had certain plus points, didn't it?
Yes, I think every single molecule or group of molecules have gone through this phase. You know, the antihypertensives, they were just reducing blood pressure, and then we had the ACRB suddenly coming and telling us that they are pleiotropic benefits. They are benefits beyond the blood pressure lowering. We had that with statins, you know, lowering cholesterol, and then the pleiotropic benefit, they have benefits. So I think the blood sugar part is now entering into that phase because remember, it was always lagged behind the RAS blockade and the statins. So it's now the era of glucotoxicity. I think glucotoxicity was important, and we became diabetologists after UKPDS. So, you know, from 70s to 90s, we were struggling to find out whether there is any requirement to take care of glucose. So we learned, yes, we need to take care of glucose to have microvascular benefits. But the problem was we were stuck with macrovascular benefits. You know, the even after good glucose control, we found that the impact on heart, on the brain, on peripheral vascular disease, and others was still lacking. And that is where I think comes the second era, which was the 2008 Accord Advanced VIDT, which started asking the question. It's not about how glucose control, but how we went about controlling glucose. You know, where you go too fast, you have hypoglycemia, you end up in trouble with good glucose control.
Also,
Then we
weight
entered
gain.
the weight gain and hypoglycemia. So we came up with the concept of glycemic, you know, metabolic composite. You know, reduce glucose without hypoglycemia and weight gain. And the third era came of the molecules, I think 2014 and onwards, where individual molecules started giving us benefit. And this is the fourth era we're entering now, which I think Tejas will talk about, is the adipocentricity. So I think your question is, I have good glucose control in diabetes. I prevent kidney problem. I prevent eye retinopathy. But in spite of that, if the BP is not under good control, if the lipids are not under good control, even with good glucose control, my patients will end up with all sorts of complications. So the holistic thing is missing when we are getting completely caged with glucotoxicity or glucocentricity.
So, do you think, Tejas, that organocentricity was an improvement on glucocentricity? Do you think it still holds some benefit at this point of time?
Yeah. So as Samit said, from an era of glucocentricity, we slowly moved away. It was a time when I think Franzo termed the ominous octet, and he made us realize that diabetes is not a disease which is only related to pancreas. It is not something which is only related to core defects of insulin resistance and insulin deficiency. And when he termed the ominous octet, we realized that we need to be more specific in terms of each organs. We need drugs which will work at different pathways so that we can not only achieve the diabetes control better in our patients, but also give other benefits. And that's how we started becoming more organocentric at that moment. Uh, Specifically, SGLT2 inhibitors came in, which worked on the kidney and the reabsorption pathogenesis in diabetes. As DPP4s and GLP1s came in, which worked on the incretin defect, which is there in diabetic. We had the metformins which were working on insulin resistance per se from beginning, and the SUs which are working on the pancreas. So slowly, what happened, I think, is that we realized that we need multiple drugs to be, and therefore more organocentric, each drug working on different organs, and that's how the benefit will be in long term, and patients will end up with a better control and with certain benefits over a time. Is what we have realized again from organocentricity is we are slowly moving from this area, and we are targeting now drugs we are using more depending on the comorbidities of a patient also, which is again becoming more organocentric. Like if a patient has a kidney related issue or a CKD, we know that we use an SGLT2 inhibitor earlier as compared to the other drugs. Or if the patient has a atherosclerotic disease, we know we use a GLP agonist earlier as compared to the other drug. And that's how an organocentric management, I think, is what has changed, and which we took it over slowly,
So
slowly.
organocentric, Tejas, you will agree with me, has still remained relevant at this point of time. It's not like thrown out of the window because of the onslaught of adipocentricity. And also, I think adipocentricity has totally shaken our the thought process as far as diabetes treatment is concerned. So, Shomit, was there a need for this, or did it happen just by serendipity?
I can still reconcile with the adipocentricity. I'm still, I think, shaken by a particular change that Tejas was talking about. I think even 5 or 6 years back, we are talking about the ominous aftercare and egregious 11 trying to tackle all the pathophysiological defects. Now that seems to be thrown out of the window straight away. We've even metformin being dislodged, and suddenly, it's just the molecules which matters. So I think that is too difficult to digest. It is still not, I think, being accepted in the physician community at large. Adipocentricity, I can understand. We started with glucose, understanding that glucose control is important in UPPDS, and then how to go about it. But what we missed is why was there this metabolic syndrome? So we are actually going back to the primordial thing to find out the reason. Remember, during SGLT2 days, we had proponents of the ketogenic model of the efficient fuel, and then hematocrit, and then uric acid, and then erythropoietin. Nothing lasted. The only thing was ectopic fat accumulation, epicardial fat. Today we know statins actually have the benefit through the impact on epicardial fat. Why, from a cardiovascular perspective, GLP-1 is scoring over SGLT2 is because the impact on epicardial fat. Ectopic accumulation of fat in the liver with MSLD, ectopic fat going to the kidneys and causing fibrotic damage and going into CKD, in the brain, and you have cognitive decline. So I think we have now found the answer to those questions, which we did not know uh, uh, um, during the SGLT2 era. Why were we getting benefits from the molecule? And it's extremely important to understand that if you go and do the primordial prevention, probably every year that IDF Atlas is upgrading in next 10 years, there's going to be a tsunami of type 2 diabetes and metabolic syndrome. I think at last we are looking at a position where we can actually backtrack by doing a primordial prevention.
So there, as you said, there was definitely a need. But now that we've got it, now that we've got the drugs, how do you think the landscape of diabetes management will pan out over the next year or two? Particularly with the advent of newer drugs into this market, where we can control blood glucose while making people lose weight quite dramatically at that.
Absolutely, Binayak. So, as adipocentricity is something which maybe should have come a long time back, is what we have realized now. It is something which is very, very basic. We've realized that a person eats more, stores more food, stores more calories, deposits more fat, and that itself leads to the problems. And just by cutting down on food, putting him into a negative balance, he will lose weight, and that cycle, as we know, the twin cycle hypothesis, it just reverses back and brings it down. So now that we have drugs which target satiety, now we have drugs which will cause weight loss, which directly we know that it reduces the body fat, which reduces the liver fat, the intra-organ fats. Therefore, it is something which is going to definitely benefit and maybe push more and more patients at any stage of diabetes to go into the remission phase is what ultimately we are looking at. The trials we know for remission till now, which were done in the past, clearly showed benefit even if a patient loses 15 kgs body weight, and it was directly proportional to the amount of weight a person lost. The number of patients went more into remission if you look at the data from both the direct study or the look at study. So our now with these new drugs, I think our aim is that only that we use them judiciously in our patients, and aim is to make that patient lose more weight and reverse the
The whole process,
cycle.
I think at some level,
The
the
whole
entire
process.
pathophysiology of diabetes is also the pathophysiology of the diabetes complications as well. The same process is taking place inside the organs, which is causing this thing. So, Shomit, I would propose to you that you link together these three centricities: the glucose, the organ, and the adipocentricity. And what would be your unifying kind of centricity that you would like to say would be of use for most physicians treating people with diabetes?
I think the first part is a public health problem, which is the what we are talking about, obesity. It is actually a public health problem, and now being enlisted as a disease. You have an ICD code also for obesity
Just
nowadays.
let me interrupt you there for a second.
Yeah.
The latest thing says that it's 23. BMI of 23 makes you obese. So all three of us here are obese, talking about obesity. So what is your view of this? Are we overdoing things a bit?
Well, Tejas, first you go first.
So I think again we have been defining obesity by with BMI, but what we now also know is that it's the waist hip ratio, it's the waist. Yeah, that is which is showing more results, and that is what is showing more data that it is more proportional to mortality or to any long-term diseases. So whether by just bringing down the BMI, are we going to achieve that benefit, or we are just going to put more patients in that obesity definition and then subjecting them to more drugs is what we have to
I think we
understand.
have to be really
Yeah,
careful about this aspect, that we don't subject more patients to these drugs just on the basis of one definition, and we should be taking more criteria into
Absolutely.
account. So coming
there's an
into
even more important area, Vinayak. Let me just come here. If I have a normal, I have my BMI is high, but suppose my waist circumference is normal. Now, some of them are being defined as clinically or metabolically healthy obese. Now, even if I have an increased waist circumference, or even if I have, say, a BMI of 24, how do I determine that I have accumulated ectopic fat, which is causing a problem? But that is extremely important to understand. Otherwise, just by having a little bit of extra belly or extra, BMI, I cannot come to a conclusion that I'm going to develop a MASLD or I'm going to develop a CKD or a heart attack. And I
now,
can't do a DEXA or MRI for all my patients.
well, in this area, what about body composition analysis that you can do to try and find out? Would that be useful to see if there's the? I personally think these instruments that we use for body composition analysis are probably not really will probably not be as accurate as we thought they could be.
That bioimpedance you're talking
Yeah,
about.
Uh,
yeah.
Okay.
Yeah, we don't know, frankly, how accurate they are measuring. Whether how there is no other way to make sure that it is giving us the right amount of body fat. I think we know that MASLD is something which is very, very directly proportional, and we have something like a fibroscan for the liver, which is we know is far more accurate and more reliable. So maybe by just screening our patients for something like a MASLD, doing their fibroscan score, and maybe could be one of the markers by which we can decide upon the intra-organ
Yeah, I
fat.
think that's a very, 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 very interesting thought that you provide, Tejas. Uh, let's move on to the drugs now. What about empagliflozin? Do you think empagliflozin, particularly in the EMPER-EDGE outcome study, showed benefit in ASCVD? It causes weight loss. It reduces heart failure. Do you think it will have a special role in connecting the gluco-organo-adipocentric treatment of diabetes? I'd like both of you to opine on this, please.
Samit, you go ahead first.
Uh, I think these are excellent drugs, but the problem is if you really want a benefit from weight loss, then you need, the recent 2025 ADA guideline tells you that from an MSLD point of view or a metabolic point of view, you need a minimum of 7% weight loss from baseline. From a cardiovascular perspective, you need at least a 10% weight loss from baseline. Now, we might have some super responders, but usually we don't see this type of weight loss with the SGLT2 inhibitors or with most of the conventional GLP-1 that we are using. They are super responders, but we rarely see such levels. I was just listening to your presentation the other day with tirzepatide. Now, 90% of patients were achieving these targets of 5 to 10% weight loss. There, I think we can go ahead and make a generalized statement. With SGLT2, I think it's excellent drug from heart failure point of view and from the point of view of kidney disease. But it's, I think, not right to say that they give you the advantage of that degree of weight loss from which you'll get the benefit. GLP-1 is, I think, better off than SGLT2 from that point of view. But still, the weight loss dosages are something we are not using. It's like 3 milligrams of liraglutide or dulaglutide. We don't use that because it's not available. I think oral semaglutide, if tolerated, I have found to be one of the most potent agents from weight loss perspective. But I think March onwards,
That's 50
exciting
milligrams,
times.
isn't it?
Even that, even the Oasis trial was done 25 up to 50 milligrams. So that again, that is not something we are using.
So, Tejas, what about? I'd like to ask you the same question about semaglutide. As far as will it connect all the dots? Because at least in the obese subset, it is showing benefits in heart failure as well as CKD as well. What are your thoughts on that?
Yes, if we're looking at the benefits that semaglutide gives us in terms of metabolic benefits and in terms of cardiovascular benefits, definitely it is there. The entire program has shown us results, though the oral sema in Pioneer did not show superiority, but did show benefit. It did show neutrality, you can say. But of course, the SOUL study and everything, which is now showing benefits. But again, when it comes to the weight loss in terms of more than 10%, I think it is the injectables which are going to give the maximum benefit. We are going to go into that era where we are going to use the injectables, you can call them avengers of the futures, is what they are being portrayed as just now. But I think when we are looking at 10 to 15% weight loss, I think it is the injectables which is going to make a difference. The orals are there. Oral sema is fantastic, doing very well. The empagliflozin, SGLT2 are giving us the push. I think we'll be able to use this combination of GLP and an SGLT2 for the very beginning, from the very beginning, mainly to look at is what I feel to push our patients to go into that kind of regimen where they get the metabolic benefits, they lose body fat mass, etc. And when they are more obese and when we want them to lose that 10-15% body weight, this is where the injectables are going to play a
Yeah,
major
and
role.
particularly with the new ones like semaglutide in the 7 milligram dose, or the retatrutide, it's massive, 20 to 25% body weight loss. So 100 per kilo person will become 75, which is almost equivalent to
Absolutely.
bariatric surgery. It's becoming that. Now, whether that translates into any kind of mortality advantage or whether that translates into reduction of heart attacks and strokes and heart failure is an area to watch out for. But I think that is the way we are going. And essentially, if you are obese, you will need to be on a GLP-1, GI stroke, GLP, GIP, plus minus SGLT2 inhibitors, because you'll need some degree of kidney and heart failure protection. And SGLT2 inhibitors, particularly DAPA and EMPA, have provided very good data on kidney and heart failure reduction. What are your thoughts on the renal and heart failure data? Shomit, if you tell us about the renal heart failure data with SGLT2 inhibitors.
So I think the first part that you said, we already have data from select trial that if you start from the primordial prevention, you have cardiovascular benefits. So that
But it's
game
only
is on.
obesity. It's not in
It's
diabetes.
only obese. No, it's only so that's the primordial part that I'm
Yeah.
talking about. So we already have some indication. The war will be, I think, between the injectable semaglutide and tirzepatide, and the trial which is going to, I think, make or break is the focus trial, which has stopped now recruiting patient, which is on the retinopathy uh, exclusively with semaglutide. If that is settled, then it's going to be it's good for us. We'll have both the molecules to play around with. And kidney and heart, I agree with you. There's an arbitrary, I think, segmentation made in some of the guidelines saying that if you have heart failure or CKD problem, choose an SGLT2. But imagine if one of my patients had an MI or 2 or 3 years back and now has developed a heart failure. Now this patient actually requires a GLP-1 and an SGLT2. So this segmentation has to be also taken in perspective or in the clinical perspective of the patient. Secondly, I think not necessarily always that the GLP-1 needs to be complemented with the SGLT2, but the SGLT2 always have to be complemented by a GLP-1 because after some time, carbophagia starts. This patient starts, getting more hungry, taking more carbohydrates. So it's the other way around. Secondly, they are not very potent from the glucose control point of view. So they always need some sort of a support. Now, I can give them a support with a metformin and a sulfonylurea if there is no compelling indication. But I rarely will come across a patient who will not have a high cardiovascular risk if I put them on a Q risk index. So I think today, I think it's very, very difficult to segregate and say that I will only give this patient an SGLT2. And imagine the discrimination between the two from the kidney point of view with a positive flow trial. The not even a SGLT2, first time a GLP-1 is showing a cardiovascular death benefit, although this is post-hoc and exploratory. But remember, in DAPA, it was all-cause mortality benefit. There was no CV death benefit from the kidney point of view. So I think that area which was so sacrosanct for SGLT2, I think is slowly gobbled up by GLP-1, except for heart failure, I think, which is especially reduced ejection fraction heart failure as well as preserve. I think that's the area where they're holding good. We have positive data with the STEP trial with heart failure with preserved ejection fraction. But remember, this is only on the symptomatic score scale, not on hospitalization of heart failure and CV. That I think is still an important area SGLT2 is holding.
So they just tell me about the new kid in the block, tirzepatide. What is your feeling about that? Give us a little overview of the data and what you think is going to come with the.
So, so the first thing is that what differentiates it from the earlier GLP-1 is the dual action of on GIP and GLP. That's where I think the effect of weight loss, what it is showing more potent as compared to any other GLPs in the past, is where it's coming from. What we know now is that at whatever dosage it has been used, be it 5, 10, 15, it has shown benefits and it has shown the amount of weight loss, which is much more, or it is almost being compared to somebody who's undergone a bariatric surgery. The data have shown a person losing more than 20 kgs, 25 kgs also with this. So again, it looks promising, very, very good. Patients are doing very well on this. Whatever data we are reading from it, it's soon about to come to our country also. And I think it is going to push back patients who are more keen to undergo bariatric surgery and lose 25, 30 kgs weight. That's where this is going to be one step earlier, where patients are going to start using this, and also, of course, with the benefits of, again, cardiovascular benefits and what data we are getting with it, which is bound to be there with the amount of weight loss and fat loss that it is showing. Uh, Tolerance wise, hopefully patients should tolerate if we are starting it well from 2.5 mg and slowly stepping it up. I think hopefully the
Providing so
patients
much
would
of
talk.
benefit. Even a 5
Pardon?
milligram dose of tirzepatide has so much of benefit.
Yes. That's what. Even a 5 mg is showing too much of benefit. So if some patients may not be able to tolerate a higher dose, they would still do well with 5 mg. We did not step up further. Is that is an advantage that we are seeing, which was not there earlier with the other GLPs, where a lower dose was not showing that
I
much
think another
benefit.
interesting about tirzepatide is, the trials with semaglutide and earlier liraglutide had showed this kind of signal about retinopathy worsening, and it was attributed to uh, tremendous glycemic control which had done it. But if you look at the trials with tirzepatide, which is actually showed 2.6, 2.7% reduction of HbA1c. In fact, if your HbA1c is more than 8.5, there's a 3% reduction of HbA1c. In those situations, there's no worsening of retinopathy. That is strange positive
Yes.
signal that you're seeing. So I think that might be another added benefit. We are into the last segment of this program, and if you have any questions, dear audience, please ask us any other questions that you might have. You will seldom have these two experts to answer all your questions that you might have about diabetes or obesity or organ disease. In the meantime, I will ask both of you one question, which you can decide what you're going to talk about. Uh, so we've talked about SGLT2, GLP, GIP primarily. What about the other drugs? Metformin, sulfonylurea, glitazones, DPP4s. Where do these fit into this whole story of gluco-organo-adipocentricity?
Right. Not you. Okay. So I think if we go one by one, metformin is here to stay for ages. It is supposed to be the life extended drug, and that's how its life is getting extended. I think metformin will always be there for us. It is still going to be used as the first line drug for our patients who come to us for the first time, newly diagnosed with lifestyle modification. Its advantages of metformin cannot be ignored and should not be ignored. There's no doubt about that. Following that, if we are talking about the other drugs, I think that's the DPP4s come in next, become, because just purely because of their safety aspect, where they are the kind of go-to drugs when we don't have to think about the side effects or the age of the patient, or we are worried about the side effects in hypoglycemia and etc. And so those are drugs which would again be still used very, very safely. That's where DPP4, though they may not give us the advantage of weight and cardiovascular benefits. And then coming on to the glitazones and
So we
SUs, I
have a
think
question from Dr. Dilip Biswas, and he says, why not pioglitazone?
you want, or should I answer, or Samit,
Either
you
of
are
you,
going?
I'm sure you won't differ.
I think let's not discount out the fact once we are talking of adipocentricity, although pioglitazone had a lot of mechanistic data saying that it's a good fat which is getting accumulated. End of the day, you're getting fat. End of the day, there's fluid retention. So it's absolutely it becomes counterproductive to have a molecule in which you start gaining weight, and even if it's a good fat, you're gaining the fat. And let's not forget today the contraindication is from stage NYHA stage 1 to 4 heart failure, and majority of our patients are actually in preserved ejection fraction heart failure. So the space of pioglitazone has actually constricted
Shrunk.
to a very small area. Secondly, let's not discount of the fact that around 30 to 40% of our patients actually have GI intolerance with metformin. Now, if we are going to slowly push organocentric drug like GLP-1, I have seen some certain subset of patients, GLP-1, SGLT2, even as sulfonylurea is doing a good job, taking the metformin out. The GI tolerability improves dramatically if you just take the metformin out. So these are the things you have to juggle with. If you bring in an agent like tirzepatide, you're talking about with a 3% A1C reduction, I do not know how many molecules will be left or will be required to be used. As a matter of fact, if you give me a choice, they are going to come in combination with insulin, which is going to be, I think, a game changer.
Absolutely.
Metformin, a GLP, GIP, agonist insulin, and you have a metformin. I don't think you'll require any more drugs, to manage diabetes.
I think that is where we are probably going to get to. There are no more questions in the chat box. We've come to the end of our time. It's been a lively and entertaining discussion today about gluco organoadipocentricity. I'd like to thank Dr. Tejas Shah from Bombay for joining us, taking time for his busy schedule. Dr. Samit Ghosal, thank you very much for having come on this program. Thank you, ladies and gentlemen, for joining it. We wish you all the best. Look after yourself and join us again when we come again with the next live online crosstalk. And we will keep you informed with another very interesting topic on diabetes, metabolism, or some kind of medical condition. Thank you very much for staying with us.
Thank you. Good
Thank
night.
you. Thank you
Bye.
so much. Thank you, Binayak, for
Thank you.
wonderful moderation. Thank you. Bye.